Okay, so good morning, everyone. Before my talk, I would like to thank IPC for inviting me to this symposium and for the opportunity to share the case today. So this is my disclosure. I have no conflict of interest in doing this presentation. And as an introduction, we know now that psoriasis is a chronic immune-mediated systemic inflammatory disorder associated with numerous comorbidities that include the wide spectrum of cardiometabolic disorders. And the dual burden of psoriasis and the associated comorbidities has a negative impact on the quality of life of our patients. And they're usually associated with an increased risk for premature death. So today, I'll be sharing this case of a 31-year-old Filipino female who works as a company nurse. She's a known case of chronic plaque psoriasis since 2012 at 25 years old. And she initially consulted our institution in 2018 due to multiple erythematous thick scaly plaques all over her body. And this is the summary of her psoriasis history. So she had been having the lesions 6 years prior to her consult with us, and it initially started on the scalp. And eventually, over time, the lesions increased in number, involving her trunk and her extremities. And during the time period, she also developed nail changes 3 years prior to consult, and joint pains and stiffness 1 year prior to consult. And she also developed a cardiometabolic comorbidities during this time, 3 years after her diagnosis of psoriasis. And these are her previous treatments or medications. So she has already tried topical medications like topical corticosteroids, vitamin D analogs. She had a short course of acitretin, but with minimal improvement. She also tried methotrexate with a maximum dose of 15 milligrams per week for a period of 5 months. And she was also subjected to narrowband UVB phototherapy, and she had been taking NSAIDs for her joint pains. So this was her examination of the skin. She had a BSA of 80% and a high PASI score of 47.4. And these were her lesions on the scalp as well as on her face. And these were her nail lesions. And her condition had a very large negative effect on her quality of life. And these were her comorbidities. In 2015, she was diagnosed with dyslipidemia and non-alcoholic fatty liver disease. And in 2017, she was diagnosed with hypertension with the usual blood pressure range of 130 to 150 over 90 and to 100. And her medications include nebivolol and a combination of amlodipine and valsartan. Other risk factors of the patient, family history, there's hypertension and diabetes, but none had psoriasis. She's a non-smoker. She's not an alcoholic beverage drinker. Other significant physical examination findings, so her BMI was 35.2 with a waist circumference of 38 inches, and her blood pressure was elevated at 140 over 90. So this patient, given her physical examination findings and her laboratory results as shown in this table, fulfilled the criteria of having a metabolic syndrome with 4 of the features out of the 5, including abdominal obesity, she had hypertension, she had hypertriglyceridemia, and low HDL levels. So these were her diagnoses. So she's a chronic plaque psoriasis, severe, with psoriatic arthritis. At the time, she is under the category of obese class 2 with metabolic syndrome and non-alcoholic fatty liver disease. So this was our initial management approach. So we want to control her psoriasis skin lesions as well as her joint pain. So she was referred to a rheumatologist for co-management. And eventually, of course, we want to improve her quality of life. And we also want to manage her comorbidities. So we want to monitor her blood pressure. So she was referred to a cardiologist for the medications as well as advice BP monitoring. We also want to address her weight, her dyslipidemia, and as well as her fatty liver disease. So we referred her to a nutritionist. She was advised low-fat, low-caloric, and anti-inflammatory diet, advised to avoid alcohol intake, and take regular exercise. At this time, she was at risk for diabetes, although with normal glucose levels, so we just want to monitor her sugars and advise low-sugar diet. So due to financial reasons, so we tried this initial management of combination of still topical medications. We subjected her to narrowband phototherapy and also methotrexate, reaching the maximum dose of 25 milligrams per week. However, the patient developed intolerable side effects to these medications, still with minimal improvement of her skin and joints. So this patient was started on biologic therapy with an IL-17 inhibitor, secukinumab. And this was her improvement after 1 year of treatment with IL-17 inhibitor. So she maintained her PASI 90 all throughout, with just few remaining recalcitrant lesions on the lower extremities, which were improved with topical medications. There was no recurrence of her joint pains, and her quality of life remarkably improved. However, there were really challenges in managing her comorbidities. At first, there was difficulty controlling her blood pressure, still with elevated levels at 150/100. So she had to be placed on quadruple therapy. So it was mebivolol, and she was shifted to perindopril, indapamide, and amlodipine combination by her cardiologist. And there were no significant change in her BMI after 1 year of treatment, and the lipid levels were still elevated. But at this time, her glucose was still normal, so we just continue monitoring. So during our second year of biologic treatment, we were faced with some challenges. There were treatment interruptions due to the COVID-19 pandemic. There were lockdowns in our country. So she had severe flares after missing 2 doses of secukinumab, and this was her after the missed dose. She also developed COVID-19 infection and missing again 1 dose of secukinumab, so she had another acute flare. And she was resumed with the monthly injections. And after 2 doses, she improved. However, we noted that the lesions on the lower extremities were quite recalcitrant. And eventually, as we continued towards the end of the second year, the monthly injections, the patient already had secondary treatment failure, having severe flares, even with our regular every 4-week injections. And these were the close-up photos of the flare. So what we did, we tried to optimize the treatment by decreasing the interval of injections to every 3 weeks instead of every 4, plus a combination with topical medications. Yes, we noted improvement, but according to the patient, the response was not as good as the one during the first year of treatment. So still new lesions develop more frequently. And in terms of her comorbidities, on the second year, her blood pressure was more controlled. Her usual blood pressure was 130/80 with a quadruple therapy. And upon rechecking, there was improvement with her triglyceride and HDL levels. It became normal, although upper limit. However, there were still challenges in her BMI. It increased from 35 to 39, and now she developed diabetes. So she was referred to endocrinologist and was given empagliflozin. So because of the secondary treatment failure with our first biologic, and there were discussions with the patient, we decided to shift her to another class of biologic, which is an IL-23 inhibitor, guselkumab. And she had more than PASI 75 improvement, and this was maintained after 3 doses, and there was no recurrence of the joint pains. And we noted improvement of her lower extremity lesions as well. So this is just a summary of the challenges that we encountered in managing this severe psoriasis with all the features of metabolic syndrome. So first, we really had difficulty controlling her psoriasis disease activity and the eventual decreased response to treatment. And this may be attributed to the presence of obesity and the metabolic syndrome, which are associated with poor response to treatment. And second, we really had difficulty in convincing the patient to reduce weight. Despite our advice, the diet and exercise, still she increased in weight rather than decreased. And we know that weight is a pivotal factor to influence the efficacy and response to biologic treatment. Third, we also had difficulty managing her comorbidities. Now, she had to be on quadruple therapy for her hypertension and as well as her glucose levels. We haven't controlled it yet. And lastly, and I think this will be still our challenge, to prevent the complications, because we know that complications are higher in patients with severe psoriasis, and their appropriate treatment options should be implemented. So moving forward, these are our plans. Now, we continue the biologic medication to control her lesions. And again, maybe we have to really emphasize the importance of weight reduction, encourage lifestyle modification by probably giving a more strict or more specific dietary plan and the regular exercise regimen, and maybe set attainable goals within feasible time for this patient. And we will be continue to monitor her comorbidities and also look closely to monitor the liver and the kidney functions of this patient. So these are my learning points. In this case, that metabolic syndrome is a common comorbidity of psoriasis with implications in both the efficacy as well as the safety of the psoriasis treatments. And early detection and treatment of these cardiometabolic comorbidities are important for long-term morbidity. And there are evidence that suggests the treatment of psoriasis with systemic treatment like what we discussed earlier, methotrexate and certain biologics, reduces the risk for cardiovascular complications. And lastly, I think as dermatologists, we can take an active role in screening as well as in managing these comorbidities of psoriasis to bridge the gaps in the holistic care of our psoriasis patients. So with that, I would like to thank you very much for listening.
Thank you very much, Lily, for a lovely presentation. A call to action at the end there.
Oh, yes.
Better. There are lots of aspects to that case, but did you have a comment?
No,
yeah.
you please.
No,
you first.
No, you go ahead. You go ahead.
Okay, sure. You could consider, methotrexate and NALF. That's an interesting choice of medications. Probably was the only thing that you had because, methotrexate and NALF would increase the risk for that, and then you add diabetes into the mess, and you get even more risk of liver disease. One thing to consider is a keto diet, because keto diet has been shown to decrease NALF also. So that would be an option there.
Okay, thank you very much for that. Yes, in Philippines, the cost of the medications, especially the biologics, is really an important concern. The patients, mostly they don't afford because it's out of pocket. We don't have support from the government or the health HMOs or the insurance. So putting them on biologics is really, really a challenge. So we were left with giving methotrexate and combination treatment initially. So that's the reason.
Oh, great, thank you for a great presentation. I wonder if you thought with these sort of patients, these ones with very high BMIs, about bariatric surgery and referral for gastric sleeve, because I've certainly had a number of patients that in this sort of high BMI that has worked very well.
Yes, I think it's a very good point. Actually, moving forward, it would be probably one of our options to recommend to the patient.
Thank you for that comment.
Congratulations for your excellent presentation. I would like to know about the beta blockers. What did you think about the beta blockers and the psoriasis?
Yes, good point. There were reports actually that beta blockers can induce flare. I don't know with your experience, but there are. And as I was looking at the case, actually I was like, oh, she is taking the beta blocker. So maybe that's one point I will be discussing with her cardiologist. Yeah, thank you.
Andy.
A nice presentation. I just wanted to highlight what I thought was the key learning point you didn't put on your slide.
Oh,
the key learning point for me was the use of secukinumab and the secondary failure, because that is seen in secukinumab patients, and it happens more often than in ixekizumab patients. And Alex and I have been talking about duration and durability, and the 23 durability over 5 years is better than IL-17 blockers in general. So I think for me, it was not surprising to see secukinumab work so well beginning and then coming off. This is a classic patient with a weight where you see secukinumab secondary failure.
Can I ask a question back? Yeah, do you think that IL-23 is a good option, shifting, or would it be a same class?
I probably, with PSA, I think it's the best option, but with weight, high weight patients, for me, they do better on guselkumab or risankizumab.
Okay, thank you.
Okay. Yes.
Just make a very short comment. I think in the long term, the key, the most important thing is that she lose weight. It's so important. It's very difficult.
I totally
How
agree.
it's very difficult by herself with diet and physical activity. The surgery would be a very good option because in the long term, it's true that some biologics lose the response, mainly secukinumab, mostly with a high weight than the others. But it's very important that she lose weight because she will improve of psoriasis and all the other comorbidities will also be easier to treat.
Yeah, I agree. Thank you.
Okay, very, very quickly, yeah.
Yeah, I would like to comment about before bariatric surgery, using semaglutide, Ozempic, was good. We had 2 cases with being obese with recalcitrant therapy with biologics, and they were controlled good, referred to be endocrinologists using semaglutide, once weekly injection, and with very good success.
Okay, thank you.
Yeah, thank you. I agree. I just learned recently I don't give that, but maybe that's, again, another option we can discuss with the patient. Yeah.
Thank you very
Thank you very much.